I just started.
Oh, there you are. Okay, cool. Let me get up.
All right. Hello, everybody. My name is Steve Rosenthal. I'm with thoracic surgery. And today we're just going to go through some basics since we're starting up the thoracic service again. It'll be myself and Dr. Argote Green. He's the new thoracic surgeon that joined us. So we'll jump right in. And the first thing we're going to start off with is just basically the chest tube box. So I'll kind of come a little bit closer for this part. And what I like to do is just kind of walk through this each section and explain it kind of in depth. It's very intimidating when people first see it. So we'll just start off from the basics. This has a little foot stand at the bottom. So when you send patients to walk, we always tell them to turn it like that so it doesn't, rub up against them and they can be a little bit more mobile. And then, that's just a kickstand to hold it. So that's kind of how that works. When you open it out of the package, on the back here, there will be in this section a vial of saline. This saline is and there's directions right here on the back for that first part. That goes into the blue tip here, which will then form your water seal. So this currently has a water seal in it, and that's because the fluid's been already placed in here. Okay. This is also going to be dual purpose. Your fluid goes in to start the water seal and establish the system, but then this is where your suction is going to go after once you get started. All right, so if we start up here, this is your suction. Now, this is one of the most confusing things that questions I get is your orders say -20. What does the wall need to be at? And a lot of people put the wall on 20. So the way this works is that you've got a bellow here. There's an orange bellow in here. And that bellow will expand to this little delta marker when you have the suction that's indicated on here be adequate. So as long as this orange accordion bellow comes out to that mark, that means that you're pulling the suction that's indicated here. This suction is controlled right here. So there's a lever here. It's like a wheel. Sorry, it's a little tough. But that's the adjuster on your suction. So if you got someone with an air leak or someone that's progressing with different orders on the suction, that's -20. And then you can see you can dial it back to -10. You go the other way, it goes all the way to 30, and then all the way to -40. Most commonly, everybody's at -20, and then sometimes we do 10, and sometimes we do -30. And the wall suction, so when this is connected to the wall, that wall suction will be at 80 to 100 typically in order to pull enough suction. If you've got really complicated patients and they've got like 4 or 5 chest tubes, you may need to crank it up to 200 to pull the suction that's on here. But it's always controlled with the box, never the wall. The wall is at -20, the wall is 80 to 100, and it's controlled here. Okay. The next section, if we just go down, is the air leak chamber. So I'm going to hook this back up to our little mini lung for this part. So this simulates a lung and an air leak here. So you can see here, if we introduce air into the system, then that'll show an air leak. The air leaks are graded from 1 to 5. So it goes from the left there. I'm sorry. On this machine, it'll be on the right, and it goes to the left. So you'll see this, the harder I push, the air leak will then show. And it's just wherever the bubbles rise as they come across, that's how you grade your air leak. We would like to know if there's an air leak, but we kind of know right when they come out of surgery. So it's never a surprise. Today I got a couple of text messages from nurses and they say, hey, this patient has an air leak, it's bubbling. Great, that's fine. We typically know that. The ones that are really more concerning is if this thing just went blah, 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 and just was continuously bubbling on and on and on and on and on. If it goes with every breath, blah, 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 and stops, blah, 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 and stops, that's what you call an intermittent air leak. And what we most commonly see is those are on expiration. So you can watch their chest rise and see if that's actually the case. So that's the air leaks. The next thing is this. and this is your titling. This is what is called your titling level. What this does is show you the pressure inside the chest cavity. So remember that the chest cavity inside the rib cage is a potential space. So when the lung's fully inflated, there's no space there. The lung is completely up against the chest wall, and this should be either pinned at the top or just not moving. And that's what you call either the lungs all the way up or it's a non-functioning chest tube. So a lot of people ask me, well, hey, this thing is not moving. That means that it's done its job and we're either the chest tube's clogged. Number two could be the lungs all the way up, so there's no space there, thus there's no pressure change. And then the third thing could be maybe a kink or something to check there. But this is showing you your pressure change. And when there is a space, you're going to see that titling go up and down with their breaths. Nothing to really report, nothing really to, I mean, if it's just stuck there and it's pinned to the top, that means that there's no space in there and, you know, everything's pretty much done its job. And, or like I said, the tube may be non-functioning. So with small pigtails, once those get clogged, then it just won't title at all because it won't be able to translate any message to the titling that there's a pressure change. Okay. The next thing is going to be your recording chamber of your output. All I really want to say about this is it is incredibly important to chart not only the 4-hour output, but the container level. So we're going to work on our system, whether or not we're going to make the marks, nurse isn't going to make the marks. For now, just do whatever you normally do. But at a minimum, if you could chart the container level, so what's your total volume output, and then the 4-hour, just do the math. So if the container level is at 800 and 4 hours ago is at 600, just put 200 in the 4-hour output section and 800 in the container level. I believe you have to set that up when you do your eyes and nose under lines, tubes, and drains in order to make sure that there's that distinction. One thing I want to talk about is what happens if the chest tube gets knocked over. So these are designed in order to be okay, that you can knock them over. Now, when they do get knocked over, you just have to make sure that you have adequate water in here to come up to the line. So if you see there on this one, it's a model, it's probably been messed up. It's low, so it should come up to that marker there. That means that you've got the correct water seal in there. This one's been, you know, very old and used, but they can be knocked over and righted up. What happens is when they get spilled over, it's really hard to see in this training, but if you all want to look later, there's a window at the top. So if you look in here and then there, you can see a small window. So what happens is the fluid fills up to the 200 mark and then it spills into the next chamber. And then it fills up to the 1090 and it spills into the next chamber. So there's a window at the top here. What you have to do is if the chest tube bottle gets knocked over, then you'll have like 60, 600, and 1500. Well, how are you going to chart that? That's a nightmare, right? So what you have to do is you have to play this game to move the fluid back and forth into, you've got to fill up the first one first. So the first thing you do is just concentrate on getting this one in here. And then you just keep on trying to get them all filled back up. Now, I can tell you from experience that when they get knocked over, you'll probably only be able to get the first level up to 180. So don't panic that you can't get it to 200. 180 is fine. And then, because the window is kind of right at that 180, 200 mark, it's almost impossible to get it back up to the 200. And then that way you have everything back to normal so you can chart again. Okay. When you're going to be changing out a container, let's say it does get knocked over and just becomes too much of a nightmare, you can't get things back to normal. These have a quick connect. So if you don't mind holding that for me. So basically the way that you change the chest tube, and we'll probably be removing these. I think the surgeon's preference for us starting up thoracic is that we're going to remove these so that people don't clamp them. A very short kind of, you know, side point is if you clamp a chest tube and they have an air leak, this is only on an air leak, you can give them a tension pneumothorax and they can die. So that's why you don't ever clamp a chest tube. Don't ever, ever, ever clamp a chest tube for transport. Somehow I think that gets done, you know, hasn't really happened here, but just know that, you know, we may remove them, but don't ever clamp a chest tube unless you're given specific instructions. And we'll go over that in another class. So if you've got to change out the container, right, that is an exception where you do need to clamp this. So sorry, just got to jumble this around. So if you're changing this out, you would go ahead and slide the clamp on. This is one of the exceptions. Okay, so you'd have that clamp, and that's so air doesn't go back into the patient and fluid doesn't come out. It's kind of dual purpose. Then right here, you've got a quick connector. You press this plastic button, and then that comes out. Just make sure when you reseat this, you hear the nice click. That means you're reseated, and check your connection. And then that way you just get rid of the old one, put in the new one. You don't need the new tubing from the new that's back here. You can just use your existing tubing and plug back in and just make sure you have a solid connection there. And then again, very, very key, critical, especially if they had an air leak, don't forget to unclamp this. So, you know, maybe take somebody in with you and like, hey, can you double check me, make sure that I unclamped or did this right until you're comfortable with that. This has a lure lock, just like any syringe system. You can draw fluid out of this. So if you need to take a sample, you can do that. One thing that's really interesting, if you ever take the time on the new one to open up the instruction pack and read, is this tubing is self-sealing. So let's say you're instructed to get a pleural fluid sample. What you can do is you can get fluid, make a dependent loop so that the fluid kind of just hangs out in here. And then you would treat this like skin. So clean it with the ChloroPrep, make sure that it's nice and clean. And then you can insert a 22 or smaller. So a 22 or 25 gauge needle can go in this tubing, and then it will seal up and it's self-sealing. And you can draw your sample directly from the tubing, and it won't make a hole, won't make a leak. If you use an 18, you just ruin the whole system and then it would have to be replaced. But 22 gauge is completely safe to do, and you can read that in the manual to kind of check that. So that is the atrium dry suction system. Another point on that note, if you get a wet suction, I think it's called the, what's the wet one called? There's the Oasis, which is dry, and then the wet one is called the Ocean. There you go. So we don't like to use the Ocean here at all. Two reasons. One, all it does is constantly bubble all night long, and some of the patients complain about that, and it just doesn't have all the same ability just to monitor and check everything. So if you get a wet one, an Ocean that constantly bubbles, then just change it out for a dry Oasis, and that's how you know the difference there. Okay, so that is the 2101 on the Oasis. This is what the packaging looks like if you need to get it from SPD or from the supply room. Once you open this up, it's got the tubing in the back, like I said, and then it's got your saline, so don't forget to make your water seal method. Okay. The last thing I wanted to go through for today's kind of basic training is dressing. So we want them to be done a very specific way, and so I'm gonna show you how to do these real quick, and we'll simulate that. We have so this was previously done with Zeroform and then gauze and then Tegaderm. So the new surgeon's preference is that we no longer use Zeroform at all, and we're just going to basically use 4x4s and Tegaderm and Cavalon. So Cavalon's a skin protector. While they're waiting, I kind of just explain this. So I don't think we don't have suture, do we? Okay. So one thing when you're doing your dressing, just to kind of point out, is when you're doing the dressing, you want to take it all down completely to the skin level. The first thing that you want to do is check that you're retaining suture. So there's a suture where we put deep in the dermis, and that's like an anchor. So you want to make sure, and you can even tug on that with some tweezers and make sure that it doesn't like rip out of the skin if they're very thin or frail. Make sure you have a good anchor point that's tied into the skin, and then check on the tubing to make sure that all your knots and all your suture on the tubing is still secure. And you can do that by just moving the tube back and forth and just making sure that the tube doesn't move and everything moves as a unit. But check your stay suture. That's super important. We've had chest tubes come out on the floor. We'll talk about that in another training session. But basically check your stay suture and all your connections there. All right. You mind holding this for me? Okay. And we'll just keep that in view. I'm going to try to keep this in the view there.
Oh,
and then we'll just do a little dressing change. So we have this? Great. All right. So we use the Pop-Tart size tegaderms. Okay. These are the, I believe they're 10 by 12 centimeter. And then this is Cavalon. I would get familiar with this product as a nurse. Honestly, it's amazing. It's a second skin. So it's a skin barrier. Also, if you have people that are sensitive to tape, you can put this down, and when you rip off the tape, you don't rip off their skin. You rip off the Cavalon, which is a skin barrier. So it's dual purpose. We're using it for mainly because it's sticky. It becomes really tacky. So what you're going to do is, the first thing you're going to do when you do your dressing change, clean all the skin off. You're going to take this guy, you're going to wipe it down wherever your tape's going to go, your tegaderm rather, okay? And you're going to let it dry. You have to let it dry. If you try to stick a tegaderm on the wet, it's just going to not work. And then we're just going to do very simple dressing. So we're just going to take, this is what comes in the 4x4 pack. We're just going to take it and do one underneath like that. And do one on top like that. And then you always want to route the chest tube to the front of the patient. The reason for that is that they don't lay on it. It's uncomfortable, and it's a high risk of getting pulled out if it's behind them. So just always make sure that you route your chest tube towards the front of the patient. And then can I get you to hold that for me? Okay. All right. Do we have anybody have any silk tape? Just some 1-inch silk tape. Okay. And then, so that's routed in the way you want. Fantastic. And then your tegaderm goes on. And you're golden. What we definitely do not want, and I know that sometimes you're going to have patients where these are going to leak. And you're like, well, the dressing gets completely saturated. I had to put all that extra dressing on there because it just keeps saturating and it's bleeding everywhere and they're leaking. There's a way to do it. You just want to be able to see everything. You don't want to completely just cover with tape and then more tape and more tape and more tape and more tape. And then, you know, we've had all kinds of mishaps with that. So the last thing I was just going to show is with the tape is you want to anchor this. And I just want to show a really specific technique that's just called a mesentery tape, where you'll basically get some 1-inch tape and you'll wrap it, touch it to itself so that it makes sure the chest tube is off the body, and it provides an anchor. So we'll give it a second here if we can find some of that. If not, we can always do that on the floor. But mainly what I want to point out with this is that this chest tube is silicone. And so if this continues to rub back and forth on a patient, fantastic. You will give them an abrasion burn, and it'll then form a blister. Had someone the other day stop me, say, what's this? Big giant blister like you get on your heel. And it was from the tube rubbing back and forth. And it can happen from tape and everything. So 1-inch silk tape, just grab like 6 inches of this. Now we ran out of mannequin, but basically what you're going to do is you're going to put it on the tube. You're going to touch it to itself. That's the key part. And then to the patient. Now what this does is it's dual purpose. 1, it helps your tube from getting kinked. And 2, it keeps it off the patient. And then 3, it even, is another anchor point. So if they are, pulling on it, you've got one safety point before you have to rely on the sutures. And, we just had one in the other day in the ICU. Patient was sedated and started waking up from being on the vent, just ripped out 2 chest tubes just like that. Just pulled the sutures right out of the skin. So it will happen to you. We hope not soon, but yeah. Since I jinxed this all, but what I would say is, on that note, we'll go through some more advanced training on that. But if a chest tube gets ripped out of a patient completely, what you want to do, very simple, you want to grab a glove, you want to place the glove over the hole, If you have time to put it on, great. But if you're panicking and your fine motor skills get lost, just simply grab a glove, put it over the hole, and call for help. And that's all you need to do. You don't need to go into any other panic about what to do. Oh my God, it's on the floor. You know, just simply, your job is to cover the hole. I recommend just a glove. It's already dirty, so don't worry about it. And then just call for help, and you stay on the patient with direct pressure and just holding that until we can come, and then somebody will page the team. So that's dressings. That is the atrium. And in another series, we'll go through, didn't want to make this too long. We're at 20 minutes. I actually have the YouTube video for this that we did a while back in the ICU. So we'll try to circulate that again, but we'll go through the chest tube box in another video. But this is your bedside chest tube insertion kit. The main thing I just want to point out with this, since they brought it in for a demo, is that this has everything in it for you to be self-sufficient with the surgeon or with the PA to put in a bedside chest tube and not leave the room. So be confident to know that once you familiarize yourself with what's in here, the beauty of it is you never have to leave the room. We took our time of bedside chest tubes from like 1.5 to 2 hours in a worst case down to like 20, 30 minutes, because this has lidocaine in it. It has syringes, needles, dressings, absolutely everything you need. It has the atrium oasis. You have the ability to do small chest tubes like pigtails and surgical chest tubes as well. All the gowns, the hats, the masks, gloves, absolutely everything's in here for the surgeon, whomever's going to do the chest tube. So all you can do is grab the box, bring it to the room, and then we'll do the rest. So thanks for attending this. We really look forward to building a strong relationship with everybody. And thanks for going through the video if you're going to be doing this at another time. And appreciate the thumbs up there. So we're going to try to get this out to the entire staff and team and have some questions with it, just so that some of the really key points are highlighted, and then you have a chance to answer those. And we'll be looking forward to meeting everybody and working on the floor and making this a great service for thoracic again. And got a long road to build this up to be a great program. So I'm looking forward to working with everybody. So thank you very much.
Thank you. Thank you.
Oh, stop. This one?
Yes.
Okay. I'm recording. Great.